Okay, good evening. I welcome you all to this PG webcast from Lady Hardinge Medical College, Kalawati Children's Hospital in Delhi. And we have an interesting case lined up for today's discussion, which will be presented by Dr. Sukriti, who is a postgraduate student at Lady Hardinge Medical College. And I have with me as faculty Professor Devnath Mehto, Dr. Mukesh Dhankar, who is the assistant professor in Department of Pediatrics, and Dr. Kamal Singhal, who is also an assistant professor in our department. So, one request to all the people who are in this hall or any other hall anywhere, please put your phones on vibrator mode so there are no disturbances in between. And the second request is that kindly note down any questions you wish to ask, punch them in, and we'll try to include them in the discussion as we go by. So, let's give it a start. Dr. Sukriti and Dr. Kamal.
So, hello. So, Dr. Sukriti will be presenting a case today, and just for a good involvement, we would expect postgraduates to be ready with their questions at the end of whatever they hear, and maybe then let's have a healthy discussion after this. And we welcome everybody else who has joined us on the web telecast. So, over to Dr. Sukriti.
Good evening, everybody. I am presenting the case of Gulbez, a 12-year-old male child who is a resident of Seelampur, Delhi. This child had presented to us at Kalawati Children's Hospital on 1st of September 2014, that is 1.5 months back, with the complaints of fever off and on from last 20 months, cough off and on from last 20 months, reduced appetite and weight loss from last 7 months, and progressive dyspnea from last 3 months. And an episode of facial and lower limb swelling lasting for approximately 1 week, around 1 month back. This child was apparently well 20 months back when he had developed episode of fever, which was moderate to high grade, not documented, and was not associated with chills and rigors. It was intermittent in nature, and evening rise of temperature was positive. This was accompanied by the complaint of cough, which had onset at the same point of time. This was dry, non-paroxysmal and non-spasmodic, and was not associated with any diurnal or postural variations. It did not lead to any dyspnea at that point of time. And at the same time, the child did not have any complaints of coryza, any ear discharge. And the appetite were well maintained at that point of time.
Can we hold on at this moment? Any of the postgraduates could describe how to elicit history about the cardinal sign of, say, cough in a patient with a respiratory disease? Anyone? What are the important attributes of cough you would like to ask in a given patient? Would you like to say something?
Please speak in the mic only, it has been provided to you.
So, we'll ask about the cough, whether that is progressively increasing, what is the type of cough, whether it is increasing, whether it is it is continuous, or the severity of cough is decreasing. Secondly, we have to ask whether it is associated with sputum production or not. Then we'll ask, because this is a 12-year-old big child, then we'll ask whether there is any difficulty in breathing or not, and when does that difficulty in breathing occurs, whether it is at night, and does it lead to any nighttime awakenings or not. And then we'll ask about any chest pain.
From one cardinal sign to another cardinal sign, which is there in a respiratory disease. My question is that if cough is is one of the cardinal signs, what are the attributes of cough we need to know? These are the other attendant signs you would ask about. That's okay, but that does not describe the cough, because the character of cough itself may help us to decide where it belongs, what possibilities exist. So what are those attributes you need to ask?
We'll ask for postural variation. Is there any increase in lying down to one side, or the cough is relieved?
Okay, so you are talking of aggravating factors. Now, what aggravates the cough? So it could be related to a particular posture. Okay, what else?
Periodic variation. Since the history is long, 20 months, is it periodic, seasonal?
Okay, so you want to see whether this is a cough which is continuous or is in episodes or has any times of remissions, on treatment or without treatment, spontaneous or otherwise. Is that what you mean? Okay, what else? Anybody else? Nimisha?
So whether it is associated with sputum production or not.
So first is dry or wet, yes. Then if it is wet, then what are the other attendant things you need to know?
So the amount of the sputum the child is producing, and
Before amount, color?
color of the sputum.
Okay, what else?
So whether it's blood stained or not.
Okay,
So then again, whether any particular posture is leading to increase in the sputum production.
okay. Anything else? One is character is wet and dry. What else would you like to know? Anybody?
Please rotate the mic. Don't speak without mic, because the people who are there on web, they will be missed out otherwise. We don't want them, because if they've taken the effort to be here with us, at least they should hear what we are talking about.
Yes.
So please use the mic when you speak. We have it with you.
Sir, firstly we'll be asking about the cough, whether it is productive or non-productive. If it is productive, then the character of the sputum which is there, the color of the sputum, the amount of the sputum, then the aggravation with the diurnal variation, like whether the child is producing more sputum in the morning, because that indicates that pent-up secretions are there in the night, and the child is producing the sputum, as in case of bronchiectasis and all. Then the whether it is foul smelling or non-foul smelling, because foul smelling sputum attributes to anaerobic organisms leading to its production. Then if it is otherwise, we should ask whether the cough per se, whether productive or non-productive, is having any diurnal variation, whether it is more in the nocturnal time, whether it is associated with breathlessness or chest pain and other cardinal symptoms of the respiratory system involvement. Then there is whether there is any aggravating or relieving factors, like if the child is using any inhalers or any medications which are given to them and response to them by the patient. Then aggravating in the form of cold food or any particular allergen exposure, or seasonal variation, or aggravation by exercise per se, or aggravation by emotional outburst, or aggravation by then relieving factors like medications or rest per se.
That's a fairly good detail, but I'm still missing something which is very important right at the beginning.
History of cough in the past, and then prolonged cough history in the family.
I think cough is one symptom which is like a sign, as much like a sign. If you watch a cough in a child, it gives you a lot of information, where it is originating from.
The character
of cough. Right? We say, does it come in spasm? Does it come with a whoop? So if you hear a whoop, if you see its eyes bulging out, you know what are you dealing with. So cough is not as much a symptom, and today's time, it's easy to watch this symptom with lots of mobile phones being available across, and parents having the capacity to make a video. You just have to tell them, okay, whenever your child starts coughing, just make a short video, and you have a symptom as well as sign, which have much better detail available to you. Sukriti, would you like to add something more to it? And in the context of your patients, what all was seen in the cough of this patient and what not seen?
So the cough of this patient was completely dry throughout this entire period, and there was apparently no improvement in the symptom of cough with all the medications, all the oral or injectable medications that this child had received. And so per se, there was no per se any hacking cough was not hacking. It was not associated with any diurnal or postural variations. It was not associated with any whoop and or any spasms. It was simply episodes of cough that had appeared, which was non-paroxysmal.
By episodes you mean bursts within a day, or you mean distinct episodes in terms of days?
They were initially distinct episodes in days. It lasted for few days, then it subsided, and then reappeared.
Initially it was had that episodic pattern.
Yes.
And what was the gap in between, and was that gap natural gap, or was it because of treatment?
Sir, the gap appeared to be near about 3 to 4 weeks initially, and however since last 4 to 5 months this has been continuous, and it gets aggravated on walking. But this has been only from last 4 to 5 months.
Whether you can say it as a recurrent cough?
Initially, sir, the cough was recurrent. There were recurrent episodes, and the time period for which the cough and fever both used to last once used to be 7 to 8 days. So it appears that cough and fever used to subside naturally and was not per se with any medications. They did not appear to have benefited with any medications that they were receiving.
How you will define this recurrent cough, recurrent respiratory tract infection this year?
Sir, initially, initially over 10 to 12 months, cough appeared for 7 to 8 days every month, and it was dry. It was non-paroxysmal and non-spasmodic, and it was not associated with any diurnal or postural variations. And it used to subside, gradually subside over 7 to 8 days, and no matter what the child no matter whether the child received any oral or injectable or no medications, the cough used to subside. So with the initial episodes of cough and fever that lasted for 4 to 5 months in this child, the child was investigated in detail by a private practitioner, where blood investigations and X-ray were done. No sputum analysis or any skin test was done at this point of time. However, on the basis of symptomatology and all these pictures, the child was started on anti-tuberculous therapy, which the child started taking from the private practitioner itself. It was not government-based, and used to take in the morning, empty stomach.
No, I was wondering, you started with a presenting history and history of present illness, and now we suddenly hear treatment history and investigation history in your present history. Why such a mix-up?
So, because this child had come to us with the as a referral with all these investigations and analysis done earlier, and accordingly we have on the basis of all these treatments given earlier, we have investigated this child further. So basically this treatment forms a very important part as a overall course of this entire illness.
But still, traditionally or conventionally, we would have a present history separate and would have treatment or other histories as juxtaposed in their respective areas. So why do you want to combine that in a present history? Any particular reason?
Sir, the effect of anti-tubercular medications over the course of this entire illness is important in this child. So it should be mentioned.
So you want to bring that up front in present history. So what do you think, Dr. Kamal? Is it right?
What if I think we can ask everybody what they feel about this, because this is one single illness which has never resolved in between. It started at some point of time, and when the patient came to us, the symptoms or signs or whatever illness, it was still continuing. There was no period for which the child was well, apparently well. So it is a continuous illness. So it's a matter of debate that should be presented in a way that now the child has come to you with a severe distress for the past maybe 15 or 20 days. This is my presenting complaint, and the rest will be my past history. The other way to say is this: maybe this is one single illness. So just for the sake of continuity, or maybe to put it in a right chronological order, maybe for the right flow, it will be better to begin with the day one itself. That this is the presenting complaint of 1.5 years, and I'll start my history of presenting illness from day one, rather than disconnecting it by describing the last 15 days, 20 days, and then going back as a flashback to another part. Maybe in a disease like maybe a nephrotic syndrome, maybe because the episodes are very disconnected, you can say that he has come to you this time with edema for maybe 20 days, and you can go back. But in such a case where there is no apparent period of wellness, maybe even when she presents it in one flow, she may not be completely wrong. Because
I think the other advantage which Sukriti did not allude to, though I was the one who was posing objections to her, it was just to stimulate her thoughts, that possibly, you see, the moment we start focus only on the current illness in a disease or a disease process which has been a kind of a continuum and is long, then the recent events will overcast the complete history. So the cough, the current character of cough, maybe there is a background illness which is a dry cough, and currently there is a secondary infection, and suddenly this cough will become wet and not dry, while the primary illness is because of a different type of cough. So therefore, taking it right from the beginning and trying to evolve and unfolding the all history, where this mix up from the conventional, where we deal with them in different parts, will go over, sometimes may be useful. I don't know how the Puritans would think about it, but at a personal level, I'm okay with this kind of presentation, as long as it's not just event reporting. One of the problems with such a history is that then it becomes only event recounting. That patient went to A institution, then B institution, then this investigation, and that's the end of it. It has to come in a detail as a continuous story, where the treatment history is part of the illness itself, because it tells you, when we say aggravating and relieving factors, it tells you, okay, this patient was given A treatment, it responded or did not respond to that treatment by itself, which is an important information to fine-tune your history or to infer from your history.
And moreover, sir, as postgraduates, I think they should master this art. I mean, a patient may not always come to you with all records, with treatments and all that. So to be able to make sense out of what the patient says, he is not giving you any x-rays or any written records. You are taking out what he is saying and you are interpreting from that. Even if you can make out this is ATT that he is taking, this is the response to ATT that is there. So this is what at a postgraduate level you should learn, because going to the records, I think it's more difficult. If I am asked to see a patient, I would rather first take a history, whatever he can tell, and at the end I will see the records, because if I see records in between, it breaks my flow, it makes things even more difficult.
Dr. Kiran, if the father says that this child has been having cough for 1 year, what all it could mean to you?
It may be, mainly we will ask about allergy associated with any asthma or something.
No. If I say that this cough is there for, say, 1 year or 14 months or whatever, 10, what is the history? How long?
20 months.
20 months. So would it mean that 20 months every day this child has been coughing, or could it mean many different things?
This may be any recurrent infections, recurrent respiratory tract infections, other thing it may be.
I'm not asking about causality. We are still discussing the character of cough. It looks very simple. It's silly that for 20 minutes we are stuck on one symptom like cough. But this itself will make most of our disease systems have very limited vocabulary. If you have a respiratory disease, what all can you have? You can have cough, which can be wet or dry. You can have breathlessness, you can have chest pain, you could either wheeze or have crackles. But you have a huge textbook of pediatric medicine, respiratory medicine, which gives you hundreds of diseases. That means it's not simply the vocabulary, limited vocabulary, it is characterizing each of these symptoms and signs, which helps us to fine-tune to or shortlist our possibilities to smaller number of patients. So, would you like to characterize this cough any further?
First, I want to characterize between as a dry cough and a wet cough.
Maybe you're not getting my point. You see, most of the time, the patients, or their caregivers have not attended a class like this. So for that parent, will it matter whether the child has coughed every day for last 20 months or has coughed most of the days with some wellness in between, or coughed 5 or 10 days every month? For them, it is a cough of 20 months because it has not gone away, it is persisting. But for you, is this information important? If yes, how?
It's mainly point towards the causality. Is it a continuous daily cough for last 20 days, or is it some recurrent cough which started with coryza for 3-4 days, then relieved after, then decreased in intensity, again started again? It mainly helpful for differentiating, for having a differential diagnosis. If it's a continuous cough having for last 20 days, even with productive sputum and all this, we can think about any infective it is a single one infective cause having for 1 of 20 days. If it's the recurrent episodes for 3-4 days.
I think 20 months, not 20 days, but what the point is trying to make is that the pattern of the cough will be able to help us shortlist some possibilities, and therefore this characterization is important. I think we need to go further, but we'll come back to this cough again, because there are still many things left around this cough which we are not sorted out as yet.
I'm sorry to interrupt you, but I have a message here which says please speak in mic. I don't know, maybe we are not clear, but let us try to speak in mic. Let it be close to your face when you speak, because there is a specific request here. Maybe somebody is missing out on this.
As the child was started on anti-tuberculous therapy from the private practitioner, the child, despite remaining compliant on the entire medication, the child continued to have these episodes of monthly fever and cough, which continued for another 6 months, while the child remained compliant for the entire period over this entire course of medications. And there was no apparent improvement in the symptoms of fever or cough, which were, however, remained intermittent, and they did not progress to any daily symptoms or any. And these symptoms, I would like to stress that these symptoms of fever and cough were not distressing for the child. They did not lead to any restriction of daily activities. The child was well able to go to school over this entire period of time, and there was no nighttime awakenings that were present during this entire period of time. Despite raising the concern to the private practitioner regarding non-improvement of symptoms of fever and cough every month, the private practitioner continued to ask them that the X-ray picture has not shown any improvement, so they should continue with the medications as advised, and over a period of 6 months they will achieve some benefit with the medications. So accordingly, they remain compliant with the medications.
That's something very strange. That's not usually the pattern, that somebody is not getting well for 6 months and would not go health shopping. So that's very strange. We'll come back to it. Let's hear you first and then we'll look at it further.
As the symptoms persisted over the next few months, when the episodes of fever and cough used to appear intermittently, the child had also started to have complaint of decrease in appetite and started to have weight loss as noticed by the parents around 6 to 7 months back. At this point of time, the child was further investigated by another private practitioner, and according to some X-rays and sputum analysis at this point of time, the child was now started on anti-tuberculous medications for the second time, and this time the child received anti-tuberculous medications from DOTS, which was alternate day regime, and initially the child had also received for 2 months injectable medications in the arm. However, despite receiving these medications, episodes of fever and cough still continued and there was no apparent improvement. Since last 4 to 5 months, the child had started to develop complaint of breathlessness, which was initially on exertion after walking for a long distance or running or climbing upstairs, and started to disturb the daily routine of the child a little. The cough also started to become continuous. It appeared almost daily, according to the parents. And further, these complaints of cough and dyspnea progressed over the next few days to a month, such that cough and dyspnea was present even at rest. And for this, the child used to go off and on to some local practitioner or some local hospital, for which he used to take some nebulizations or IV injectable medications, and with which these symptoms of cough and dyspnea used to improve, although these symptoms improved only partially and used to reappear after some time.
What is that sometime?
Sir, initially the symptoms were appearing at a longer distance. They were initially appearing at 1 to 2 weeks, and he required nebulization at intervals of 2 weeks around. This was around 4 to 5 months back. However, from last 2 to 3 months, the symptoms of cough and dyspnea were progressively increasing. However, the pattern of fever at this point of time remained the same as earlier, which was intermittent in character and appeared over a few days, over intervals of weeks. And progressively there was a restriction of daily activities of the child. The child could not go to school, child could not walk for a long distance, and could not even go to market nearby his house. And as these symptoms progressed, there was a time when 1 month before our presentation to the hospital, the child had episode of severe dyspnea, and there were also, along with this, there were appearance of swelling over the face and over the feet, which was noticed around 1 month before the presentation to our hospital. This time was not associated with any palpitation, any cyanosis, or any decrease in urine output. And with these complaints, the child had presented to Vallabhbhai Patel Chest Institute, and where he remained admitted for around a month, and was also admitted to the ICU and required additional respiratory support for around 3 to 4 days. Gradually, there was improvement in the symptomatology with the medications that they had provided, which included all nebulizations, IV antibiotics. Over this entire period, the antituberculous therapy of the child had continued and was not stopped. From Vallabhbhai Patel Institute, this child was fit for discharge after about a month and was referred to us for further management, and whereby sputum, blood, radiological and echo testing along with skin testing was also done. There is no history of any recurrent skin infections, any diarrhea, no history of any skin rash, photosensitivity, joint pains or joint swellings, or any oral ulcers in this child.
From your history this far, what are the possibilities which come to your mind? You have a child who has fever and cough, fever which you said was low grade, not very high grade at any point of time, cough which is almost coming and going, initially episodic and now persisting, and a breathlessness of a later for last 4 or 5 months. So what possibilities come to your mind with this kind of history? You have a patient with chronic low-grade fever, not documented. You have a patient who has cough which is gradually increasing, largely dry, and with breathlessness. So where do you think the problem lies? And what possibilities will you keep?
So firstly, I would like to suggest a post-infective etiology in this child, because initially the symptoms of cough and dyspnea were not distressing. It started with symptoms of fever and along with cough,
Sir,
which
sorry to disturb, sir. Some people may have joined late. If she can maybe summarize this history, and then maybe we can think of these, because at that time the reception was breaking, they say. So please summarize, then we can discuss this.
So, to summarize the history, is a 12-year-old male child who had presented to us with the symptoms of off and on fever and cough initially from last 20 months, with onset of progressive dyspnea and cough from last 4 to 5 months, and along with this reduced appetite and weight loss from 7 months, which the symptoms being progressive over the last 3 months for along with the appearance of facial swelling, and now improved on oral and injectable medications along with the respiratory support provided from Vallabhbhai Patel Institute, with no history suggestive of any recurrent skin infections or diarrhea or any skin or joint involvement suggesting of any connective tissue disorders.
Why do you have a connective tissue disorder in mind?
Sir, because this child has progressive underlying lung involvement, which can be a feature of many of the connective tissue disorders.
No, but cough is a symptom of involvement of airway or parenchyma?
Airway.
Airway. So which connective tissue disorder will give rise to changes in the airway to begin with? Because he started with cough. His problem of breathlessness are more recent. So what do you have in mind?
Sir, a child with an underlying connective tissue disorder, when superimposed with certain infective symptoms like fever and cough, which appeared in this child, may have developed aggravation of the interstitial lung disease, which might have also have an onset.
No, now you are introducing a new dimension, which is ILD. But before we get into that trap, what makes you feel from your history that there is any connective tissue disorder involvement?
Sir, a progressive lung symptoms along with the weight loss and reduced appetite can be a feature of certain connective tissue disorders like Wegener's syndrome, Church-Strauss syndrome.
Wegener's would not present with only breathlessness. Wegener's presentation would be epistaxis, repeated persistent pneumonia, time and again. Fever is a predominant symptom there, which you let us understand from the family once. How important was this symptom of fever? भैया, ये जब शुरू में इसको बुखार हुआ था तो कितना बुखार रहता था इसको? बुखार नापा नहीं था. अब ये ले लीजिए. बुखार नापा नहीं था, पर वो तेज होता था कि हल्का होता था?
तेज होता था.
खूब तेज होता था.
हाँ.
अच्छा. और डॉक्टर ने कभी नाप के कहा था कि बच्चे को बुखार है?
नहीं.
डॉक्टर ने कभी बुखार नहीं. आपको महसूस होता था, डॉक्टर को महसूस नहीं होता था. डॉक्टर नहीं कहते थे बुखार है.
जी नहीं.
तो फीवर तो आपका गया. It was never documented, and doctors never felt that child was febrile. So maybe there was some. It cannot be a high grade fever from what we are understanding. Okay. और बुखार के साथ और क्या समस्या थी तब?
बस बुखार होता था, इससे पसली चलता था.
पसली चलता था. नहीं, शुरू में आपका इलाज 20 महीने पहले शुरू हुआ, जो प्राइवेट में आप डॉक्टर को दिखाए थे, तब किस किस बीमारी से गए थे आप?
ऐसे बुखार लग रहा था, इसको खांसी होता था.
खांसी होता था. खांसी ज्यादा था, हल्का था?
हल्का फुल्का होता था.
हल्का फुल्का खांसी होता था.
तो फिर कहीं से भी दवाई ले लेते तो सही हो जाता था.
अच्छा, तब सांस फूलता था?
हाँ, नहीं, सांस न फूलता था.
तब स्कूल वगैरह जाने में कोई दिक्कत होती थी?
नहीं, कोई दिक्कत नहीं.
तब कोई सांस नहीं फूलता?
कभी नहीं.
सांस अब फूलना शुरू हुआ?
हाँ, सांस ये अप्रैल के बाद कौन सा महीने?
जुलाई.
जुलाई से बुखार सांस फूल रहा है. उससे पहले नहीं फूलता था?
नहीं.
स्कूल जाते थे, अच्छे से जाते थे? तुम तो यार बड़ा अच्छा बताते हो.
You should involve the children in history taking if they are more than 5 years. They can give better history. And you see the child is knowing from July, specifically, because he is sufferer.
Yes, we can always supplement history from the patient himself or herself when they are old enough to understand and describe their symptoms well. Remember, yes, they can also many a time just express what they have heard from their parents. So one has to, that as Dr. Saab said, that 5 years or older children who are able to express. This one is 11 or 12 years?
12 years.
12 years. He is old enough to understand. He is a school-going child. So maybe he'll be able to describe more. But its age alone is not enough. It's also their understanding of the sickness or of the symptoms which is important. So breathlessness came again. और जो पहले जब खांसी रहती थी उसमें कोई बलगम वगैरह आता था? कभी नहीं आता था, बिल्कुल सूखी रहती थी और कोई पसली नहीं चलती.
कोई पसली नहीं चलती. ऐसे कभी कदाल जब बच्चा था ना तो पसली चल जाता था. हाँ तो फिर भाई दवाई वाई खिला देते तो सही हो जाता है।
अच्छा, पहले बचपन में इसका सांस चला?
हाँ नहीं, पसली चलती थी वैसे।
पसली चलती?
हाँ।
तो कभी खाते खाते यहाँ छाती में दर्द या कुछ ऐसा हो कि जब छोटा था तो बहुत ज्यादा दूध जमा हुआ निकालता हो, ऐसा कुछ?
नहीं, ऐसा कभी नहीं।
ऐसा कुछ नहीं। अभी कोई ऐसे यहाँ दर्द तो नहीं होती बेटा तुम्हें, जलन या दर्द तो नहीं होती छाती में?
अभी कभी कभी होता है, जलन होता है।
नहीं, जब ये खांसी बुखार ये सब कुछ शुरू हुआ, जब ये तकलीफ शुरू हुई, तब ऐसा कुछ तो नहीं था?
नहीं, ऐसा नहीं हुआ था कभी।
नहीं हुआ था। Why is that important?
Any history suggestive of GER which causing gastrointestinal burning pain and causing aspiration of
Yes,
the
because
gastric.
a gastroesophageal reflux disease can explain all of these symptoms. It can give rise to initially cough with wheezing, which he had earlier when wheezing was described, and now again when you are describing that he used to get better with nebulization, which is going on to a situation where you have breathlessness, which may be indicative of many things, of which one could be a parenchymal disease, which is possible with repeated aspirations. You can have repeated aspiration leading to bronchiectasis. You could also have repeated aspirations, reflux leading on to an interstitial lung disease. It is well described. So this is an important history which should be taken in this situation. Any other ideas from the audience? Any part of the history which or possibilities which you would keep and would like to know from Sukriti about? Silence is golden.
Foreign body aspiration, especially vegetable origin, they will give recurrent respiratory tract infection. When there is infection at that time, and it will swell, and all the features of wheezing and cough we will get, and breathlessness. And around 25 to 50% cases, there may not be history of foreign body aspiration.
Yes, it's an important thing to remember that a chronic cough, one of the reasons could be a forgotten foreign body which has given rise to a chronic suppurative disease. But in this particular patient, the important distinctors which will tell you that possibly we are not dealing with a foreign body are, what are they? You want me to tell, or you will be able to remember it?
Sir, episodes of the progressive symptoms of dyspnea along with the weight loss and decrease in appetite, which do not suggest any foreign body. And sir, along with this, the onset of illness which he is ascribing 20 months back was with fever and cough, which was intermittent, which is not really a...
I think the most important distinctor in this is absence of a wet cough and expectoration. Foreign body, a forgotten foreign body will give rise to a chronic cough, and only when it gives rise to chronic suppuration. And then you should have a you would have fever, but it will be a wet cough. It cannot be a dry cough. And breathlessness will be much later when you have either a cor pulmonale or you have a small airway disease associated with that bronchiectasis. So absence of a wet cough is a big marker against the presence of a foreign body as a cause of this prolonged illness. Any other possibilities? Yes? Why don't you come in front? The seats in front are all at the same price.
Vinod, please pick the mic.
Quick. People at the back, please come on this side.
Please come on the front seats.
Yes.
History suggestive of any multi-site infections, immunodeficiency?
That she alluded to, that it was not there.
Skin infections, diarrheas, and oral ulcerations, arthritis.
And any history suggestive of rheumatic heart disease?
I asked for arthritis and any skin rash. That is all what I could ask.
Why do you want to know about rheumatic heart disease?
Suppose it's initially actually a heart disease and secondarily is repeatedly presenting with the pulmonary complaints after it has progressed and led to heart failure.
So the cough you think was initially because of heart disease. Heart disease straight away giving rise to cough is how common?
And
he has been having cough for months and no cardiac symptoms. Cough as a cause where the primary cause is heart disease. When will cough happen? The cough will happen in two situations. One is that you have cough as a part of CHF,
right,
where the CHF symptoms would predominate over the cough as a symptom, which we are not finding in this case. The other possibility is, which is very less commonly seen, a huge cardiomegaly which is causing a compression of one of the bronchus and this giving rise to a collapse, which is much less common. There also breathlessness is more common than cough. So I would consider that as a relatively remote possibility given the complete picture. Yes, you're right. Breathlessness can be secondary to heart disease, but their pattern would be different. As I said earlier in my comment, that vocabulary of all these organs is very limited. It's the pattern. Most of medicine is about pattern recognition. It's the pattern of the primary symptom itself, or the pattern of the symptomatology, the complete symptomatology, which gives us a clue. But it's anyway, it's a good question, so that because it answers some of the doubts which may be there in the audience. You want to add something?
I would just
Would it be H-type tracheal fistula?
Can it be H-type fistula?
So, presentation should be.
So the cough would be dry in that case?
Why should cough be dry in H-type fistula? H-type fistula is by aspiration. It won't be dry.
It wouldn't be dry.
Okay. What will be the most important character of cough when it is H-type fistula? Yeah. Carry on. You can.
The cough whenever he eats.
Yes, it's a relationship with eating, feeding. There has to be a temporal relationship of the cough with feeding, instantaneous or within few minutes of feeding. It would not happen that child had meals in the evening and cough at night. It's almost instantaneous. No, it may be delayed by a couple of minutes at the most, because sometimes it takes the track is such that it takes a while for the aspirate to reach there. But you would not have an H-type fistula which has not got any relationship with choking or feeding difficulties, which is a predominant symptom with cough there. So that's an important character we have to remember. Dr. Kamal, you wanted to add something?
Sir, I have a question here.
You have an access to more questions back there.
Dr. S. Kumar from Lucknow. The question, I don't know at what point of history or time it was framed, but the question says, history of cyanosis could be considered in the history of chronicity. History of cyanosis.
Okay.
When the child had presented with the acute episode of swelling and increasing dyspnea and discomfort, I had asked for history of cyanosis, so there was no cyanosis.
Okay. Okay, with this, I'll take it from here. Whatever history she has told, we see patients coming to us and saying, Doctor साहब इसको तो 1.5 साल से खांसी आ रही है, इसको 1.5 साल से सांस फूलता है, more or less like this. So what are the indicators in a history which will give you a hint that this is not a minor illness which is going on for a long period of time? This is something severe or something important pulmonary illness. So what are markers in a history which will give you an indicator? Now when I have a look at the child, I am sure that there is something major going on, not something. So if I forget this part, what is there in a history, if suppose it is this long, which indicates that this is a major or maybe a severe chronic respiratory illness? Please use mic. Yes, guess. Any guesses?
Not gaining weight.
Good. If somebody is not gaining weight,
retardation actually should be there. So long chronic history.
Yes.
Chronic cough.
Any chronic history, if a child is not gaining weight, that means it is something important, severe. Anything other than this on history? Please pass the mic.
Interfering with daily activities.
Very good. If these problems are interfering with child's daily activities, which means he cannot sleep, he cannot play, he cannot eat, he cannot go to school. If it is affecting his daily activities, it is something significant. Anything else? Yes, come on.
Sir, a recent cyanosis of the lips.
Okay, cyanosis, fine. It's there in the history and examination also. Other than this?
Clubbing. Recent.
We are not going into examination.
I'm not sure whether I agree with that fact that chronicity and cyanosis have any relationship. Cyanosis may be an acute decompensation. It just shows a decompensation which can be acute or in a lung disease. Chronic cyanosis is, except for the COPD in an adult with blue bloaters, is almost uncommon in children, right? You could have with ILD some degree of hypoxemia or subtle cyanosis, or deep cyanosis which parents would pick is almost unheard of or is very uncommon, right? So we do not have those kind of illnesses in children where you would have a chronicity and clubbing going together. They do, both of them do start with C, but they do not necessarily are associated. I would rather link clubbing or cyanosis more with a decompensation at that point of time. But sometimes, once that decompensation happens, if it has happened slowly over a period of time, the child may not be as dyspneic or show as much air hunger. He may be tolerating that discoloration of the lips or the presence of sinuses. Vis-a-vis a child who has an acute decompensation, who would be having an air hunger at that point of time, what would be often did. So you would either see cerebral irritability or you would see a cerebral depression with that. You would not have a walking child with cyanosis which is of acute. In that situation only you can say yes, it's a chronic cyanosis, and usually that is more subtle than marked.
Also the
Chronic cyanosis which is visible to the parents is largely seen with cyanotic heart disease. It's not seen with lung.
Otherwise, if there is a history of prolonged cough, then if it is productive, it is giving purulent sputum, it indicates that something significant is there. If there is a persisting kind of a fever which is there with this cough, it is significant. So there is a question here which says prolonged cough, can we think about HIV? I think she has covered this. She has tried to cover the points which indicate that the child may be immunodeficient. It could be primary or secondary. So she has said recurrent infections and all. So it rules out HIV also.
Past history, since the age of 2 to 3 years, the child has episodes of cough and some fast breathing noticed by the parents, which appears at intervals of around 4 to 5 or 6 to 8 months, and these symptoms usually subside on oral medications, and the child has not required nebulization, and they usually last only for a day or two or up to 3 days. And there is no history of any other prolonged illness in the past or any period of hospitalization in the past. For the family history, the child is a second born male child and second birth order, and there is no history of any prolonged illness in any of the siblings. History of tuberculosis of the skin is present in the mother, which appeared 4 to 5 years back and had improved on ATT from private hospital. And apart from this,
is this a history of contact? Is there a history of contact present in this child or not present in this child?
So history of contact has not been elicited in this child because there is only skin tuberculosis which is not transmittable. However, when another person in a family is giving a history of tuberculosis, sometimes we suspect a common source which has led to tuberculosis in more than one person in the same family.
Anybody else in the audience would like to say what is the history of contact for tuberculosis?
So, for all the epidemiological purposes, we say that within 2 years of duration, if the patient is exposed to a person with known tuberculosis, which is supposed to be infective, like pulmonary tuberculosis with cavity, which is a open case, or for other purposes, any extrapulmonary TB, if it is not assessed for pulmonary involvement, is a potential source of tuberculosis. So for all the epidemiological purposes, any open case of tuberculosis exposing the child within 2 years of duration is taken as contact. Otherwise, extrapulmonary.
So she raised, to my mind, you answered the question, but not with as much clarity as possibly we all need. But you raised 3 very important things in your definition of history of contact. One thing she raised was past 2 years, exposure in last 2 years. Why last 2 years? Why not 5 years? Why not 10 years? Why not 1 year? Why 2 years? There has to be a reason. So why 2 years? Anybody? You want to say?
Sir, this is based on the latency of symptomatology caused by the tubercular organism, which is which
you
we
mean
define.
TB bacilli takes 2 years to produce disease?
If it has to manifest, it will manifest within a period of 2 years, and beyond 2 years we.
You're not saying latency of symptoms. What you're trying to say is that the risk of developing the disease after developing infection is maximum in first 2 years. This is what you're trying to say, which is right. Most of the, actually, if you see, only 10% of the people who are infected develop the disease over their lifetime if they have no other immune deficiency. Immune deficient patients have a 10% risk over every year, right? So that's a different situation altogether. We are talking of a 10% risk, lifetime risk in patients who are immune competent. However, 50% of this risk is in first 2 years, max of which is within first 1 year of exposure. So in pediatrics, it is said that exposure to infection to disease is almost a continuum. So if it has to happen, it will happen in a short period of time after infection, and that is also the philosophy behind using chemoprophylaxis in children, because if you identify them as to be infected, you consider that they are likely to develop disease and therefore you intervene, right? So that is the reason why we use this period of 1 or 2 years, and 2 years is... The other important thing which Dr. Bhavna added was that this has to be a cavitary tube. Now, Dr. Bhavna, do you know what is the inter or intra-individual variation on reading an X-ray about cavity? In a study which is published in Stiblow's textbook, okay, I'm forgetting the name of this textbook on TB, where it very clearly says, Toman's textbook, it very clearly writes about a study done in TRC Chennai, wherein in about 1/3 of the cases, 2 radiologists could not come to an agreement whether there was a cavity or there was not a cavity. So is it cavity which we use? No, we do not use cavity. What we use is a smear positivity, an infective case. So if you are in contact with the smear positive pulmonary case, then it is definitive. Now this is again a very, very kind of a precise definition, which leaves little room for the way we deal with our garden variety of patients. If you look at a technical definition or a research-like definition, then it should be exposure to a smear positive case in last 2 months. And this kind of concrete definition is largely used not for the purpose of defining contact, but for the purpose of exposing a child to chemoprophylaxis. Okay. So if you are exposed to a smear positive case and you are below up to 6 years of age, then you are given INS prophylaxis. That's a history of contact from that viewpoint. But here we were talking of history of contact in a child who is likely to have TB. There, if you read the national guidelines, IAP or RNTCP guidelines, it has diluted it further. It says any form of TB which has been treated in last 2 years and patient looks likely to have TB, this should be given credence. Then why have we diluted this? We know that lymph node TB, and as she very rightly said, the skin TB is not communicable. So this is not history of contact. Yes, you are absolutely right. But we also know that all our patients with TB do not get fully investigated. If suppose this patient has gone to a dermatologist and has got only a skin lesion and they biopsy and find TB, they are not going to do further investigations to know where all in the body this TB exists. And there may be a concurrent pulmonary lesion. So for lymph node or other extrapulmonary TB, nearly 1/3 to 40% of the patients can have a coexistent pulmonary lesion. And this pulmonary lesion may be without significant pulmonary symptom. And therefore, for the purpose of the definition of contact as given in our guidelines, any form of TB in last 2 years is considered relevant. Exposure to a patient who is smear positive or likely infective or pulmonary case makes it much more important or much more relevant in that case. So that's how the history goes.
Dr. Sarika from Rohtak, she says, contact with a school teacher 30 minutes per day. Is it a contact? I'm assuming it to be a sputum positive.
Well, this will take us to a discussion away from our case, but I will quickly answer this question and making sure that we are not taking more questions on contact after this, simply because that's another discussion altogether. Now, the contact is or the exposure resulting from a contact is dependent on several things. It is dependent on presence of a infective pulmonary lesion. It is dependent on the presence of cough as a predominant symptoms, the severity of cough, the expectoration, the cough hygiene, the ventilation in the room, and the closeness of the contact. Now, if this student is sitting next opposite to the patient, in front of the class teacher, and she is coughing, and her cough hygiene is like she is writing on the blackboard or on the case sheet, and doesn't have time to put hanky on her mouth when she coughs, and puts it later on to clean her mouth, this child has much more exposure. And it's a winter time and all the windows are closed and there is no ventilation, this child has a higher exposure. Same 30-minute contact in an open field to a PT teacher would not mean anything. So, there are studies which have shown that such contacts with daily caregivers or in school time setting, both from student to teacher and teacher to student, have been verified and have shown that the transmission of disease is possible. So this duration by itself is a casual contact is difficult to spread disease, but a casual contact is an occasional contact. Teacher contact with a teacher cannot be called a casual contact. You are going to be with a teacher at least for one period of learning every day. So that is not a casual contact. So let's go further.
Birth history: the child was full-term vaginal delivery at home and had cried immediately after birth. The birth weight has not been documented, and the neonatal period remained uneventful. The developmental history: the
significant there in the development?
No, not significant.
What specific thing would you look for in a child with fever, cough and respiratory distress which has appeared at the age of 10 or 11? Right. So would you think there can be any contribution by the developmental history in this situation?
Sir, reducing school performance of the child and delaying studies over the last few years.
So not as a causality, but possibly as an impact
on the daily life.
Good. Okay, let's go further.
The dietary history. Presently, the diet of the child is significantly reduced and is taking 1240 calories against 2190 calories as required according to the age. And this is the present. The pre-morbid cannot be recalled by the mother because it takes us back to around 20 months. And the protein intake of the child has also significantly reduced and is presently only around 18 grams, which is against around 28 grams, which is appropriate for the age. And then, sir, apart from this,
I know it is going to be difficult to take a pre-morbid history of diet in a child with such a long-standing history, because recall itself would be difficult. But do you think this child is not growing well because of his disease or because of his diet, or both?
Sir, it appears that primarily the disease process has affected the diet of this child and is causing weight loss. Because initially the parents, when the illness had started, the appetite was nearly normal and has decreased progressively over the time since the symptoms have progressed.
So for the differentiation here would be, you look at the average diet. No, is it dietary practice or dietary deficiency, which may be because of poverty or economic? So it can be either because of ignorance or non-availability of food. If that is not the issue, then it is disease related, right? So what do you think is the likely cause in this? You feel it's the disease which is causing the...
Sir, in this particular case, it appears that the disease is causing the process, because the parents have clearly told that even when the child is admitted to the hospital where adequate amount of food is being supplied in hospital for the patient, the child is not feeling good enough to take the entire meals and finish the entire meals that are being provided.
Let's go further.
Immunization history. Sir, the child is partially immunized in the initial few years of life. The parents are not knowing when the last injectable vaccination was received by the child. And at 10 years, the child was not immunized. So the child is partially immunized, but they don't really remember until what age. And sir, socioeconomic history. Sir, the five-membered 5-membered family living in a pakka house which is rented and consists of 2 rooms, and there is 1 door and 1 window in each room with adequate ventilation. The water source is from a nearby municipality, and 1 bathroom is there which is shared by the landlord, and both the parents are uneducated entirely. The father works as a non-skilled self-employed laborer earning around 3,500 each month, and the per capita income falls out to be 25 per month, 25 per day accordingly. So they fall into a lower socio-economic status according to the modified Kuppuswamy scale.
Is there overcrowding there?
So there is a phenomena of overcrowding.
I mean, in this condition, is there overcrowding?
This phenomena is present overcrowding. 5 members living in 2 rooms, and and all the members are above 100 centimeters, which is
there is a social definition of overcrowding, and there is another medical definition which is relevant to us. So what that age group is a social definition of overcrowding. That above this age, not brother and sister, it's a social definition. What matters to us is this medical definition, maybe the floor area. That will give you, because if we are thinking in terms of airborne diseases, then ventilation will be a more important criteria for me to call it overcrowding.
So do you have more detail on the housing? No. But I think the point which Dr. Kamal has made is very pertinent, that there are several definitions for overcrowding, and here in this context possibly, I do not know what the definition is referring to, but how much can you describe?
They have been taught, sir. They have been taught this in community medicine, that there is a
social
definition.
Is fine. Medical. What is the definition for that medical overcrowding?
Sir, as per the floor area, they call it overcrowding. So maybe if he can give an idea that my room is this big, so around 100 meters. I don't remember that criteria. Okay. But going by floor area, you can call it overcrowding.
So there is something we all need to go back and read. Okay. Let's go further.
So summarizing the entire treatment history, category 1 antituberculous therapy received from July 2013 to January 2014, entire 6 months being completed. And further category 2, the second time antituberculous medications being started in April 2014 from DOTS and being continued till date. And presently the child remains on continuation phase from DOTS itself. And off and on the child used to receive nebulization along with injectable medications from local hospitals. 1 month before presentation to our hospital, the child was admitted at Vallabhbhai Patel Chest Institute, and where antituberculous medications was continued. Respiratory support was provided for approximately 3 to 4 months, along with injectable medications, nebulizations, and followed by shifting to inhaler therapy 12 hourly, and was along with oxygen over the time, and this child was then discharged on oxygen daily along with oral medications and MDI inhalers, with ATT being continued. The investigations done at Vallabhbhai Patel Institute included skin testing for aspergillus, and along with sputum investigations,
I think we'll talk about investigations once we have heard more about the examination. So can you, yeah, you want to ask something? No. So idhar bitha do isko. Demonstrate and speak as you go.
We have a very thin-built child who's sitting with us comfortably on the table provided by us, and upon examination, the heart rate of the child is 144 beats per minute, which is regular, and pulse has been felt in the right radial artery. It is good volume, and the peripheral pulse is being palpable with no radiofemoral delay. The respiratory rate of the child is 48 per minute, regular, and is abdominothoracic, and with presence of suprasternal, supraclavicular, and intercostal retractions. The BP of the blood pressure of this child is 110 by 70 millimeters of mercury, recorded in right upper arm. The temperature of the child is 98.7 degree Fahrenheit. The saturation of oxygen as recorded by pulse oximetry was 89%.
What is most striking the moment you see this child? You said respiratory rate of 48. At this current time it looks higher. Maybe you saw him in a better state at that point of time. That's possible because he tends to have times when he is breathing faster than usual. So, but what else is immediately visible to you?
Significant dyspnea is...
Significant dyspnea. Dyspnea is a feeling. Significant. You call it dyspnea, or you would... what? Dyspnea is not a sign. It's a symptom.
Okay. Features of respiratory distress including chest retractions and tachypnea.
So you see tachypnea and?
Visible chest retraction, suprasternal and supraclavicular.
Suprasternal?
Supraclavicular and even in lower intercostal.
Anything else?
Shape of the chest is...
shape of the chest? Because that's...
funnel shape.
Inspection itself is going to give us a lot of answers about the possibilities. So, what is the pattern of this respiration?
Mainly abdominal movements appear to be more prominent in
mainly
this,
abdominal. So, when do you get mainly abdominal movements?
Sir, we can get in underlying lung disease, presence of
what
any
kind of lung disease?
Sir, fibrocavitatory diseases causing destruction of the underlying lung parenchyma.
Okay, one is that there is hardly any parenchyma, so there is little expansion. Or?
Diaphragmatic weakness can lead to...
diaphragmatic will not lead to abdominal. It is the intercostal which will lead to abdominal. If your diaphragm is weakened, then how can you have abdominal breathing?
Intercostal.
Huh. Or? If you have a child who has, this is a child who where we started with a past history of obstructive illness, right? Past history of an obstructive illness, chronic cough, followed by breathlessness. It could be bronchiolitis obliterans, it could be any, it could be, maybe he is an asthmatic who has developed allergic bronchopulmonary aspergillosis. So what will be the typical feature of chest in that situation? Hyper-expanded. In a hyper-expanded chest also, you would not have further scope for expansion in the thoracic axis. Your expansion would be more in therefore respiration would be abdominal. So, the presence of abdominal. So, does this child have any signs of hyperinflation?
Signs of hyperinflation are not present. The
Are
chest
not
is
there.
not elliptical
You are going
in
to tell us the
appearance.
measurement after you talk about details of your journal physical. We'll come back to this question at that point of time. So, please proceed.
Sir, there is a question. Priya from Hyderabad. What's the relevance of BCG scar in this case? Relevance of BCG scar in this case?
I think that's just for a sake of completion. BCG scar by itself will neither increase the risk or decrease the risk of TB at this age. So we'll leave it at that. Carry on.
On anthropometry, the weight of the child is 19.8 kgs, which is less than the minus third standard deviation according to the WHO guideline. And the height of the child is 128 centimeters, which is less than third centiles according to the WHO standard charts, and is around 81% of the median for age. The BMI of this child is 13.1 kgs, which is again less than fifth centile of the standards for age according to the WHO charts. And so following the general physical examination.
ठंड तो नहीं लग रही? ठंड लगे तो बता देना. डर तो नहीं लग रहा? कुछ नहीं करेंगे, कोई इंजेक्शन नहीं लगेगा. कुछ भी नहीं करेंगे, अभी भेज देंगे देख के, ठीक है? जैसे वार्ड में देखते हैं ना, वैसे ही देखेंगे आज वहाँ नहीं देखा, यहाँ देखेंगे, ठीक है?
There is no abnormality in the hair, there is no facial dysmorphism, there is no skin rash present over the entire area, and there is no any other cutaneous nevi or any significant scar marks are not present. No pallor is present, there is no icterus, no cyanosis, no edema, no lymphadenopathy. Clubbing is present, which is grade 2 in the fingers. Coming to the respiratory examination, on upper airway examination.
Can you demonstrate clubbing on this side? एक बार वहाँ उसमें कैमरा में दिखा दीजिए सबको. There is a question by someone that is this child anxious? So what is your response to that?
Child appears to be sitting comfortably. He does not appear to be anxious.
No, I would say he's little anxious, but he's more anxious because of the cameras. He's not used to a ward where there will be cameras relaying him.
Anybody would get anxious.
But his anxiousness is not because of
the
distress. Because had he been distressed with anxious, then he would not be responding to our questions that easily with easy flow. He is very coherent in his answers. So his anxiety perhaps more is because of this artificial setting with all these camera people around him. आज तो तुम टीवी पे हो बेटा, look, he's
smiling.
So that's the point I was trying to make. Okay, please demonstrate the clubbing.
Grade 2 clubbing, as I said, should obliterate the angle which is present between the nail bed and the skin. So this can be demonstrated in this child by through demonstration of shamrock window, which is where two fingers are approximated. हाथ दोनों ऐसे, दोनों उंगलियां ऐसे जोड़नी है अपनी. So we can say the angulation between the nail bed and the skin has been obliterated in this child. On upper airway examination, the nose, the nares and the nasal cavity and the oral cavity and the oropharynx do not show any significant abnormality. On chest examination, on inspection, the chest appears to be funnel shaped, and there is overall a decreased movement of the chest and per se more on the left side. And visibly there is
decreased movement.
Yes,
Can
sir.
you demonstrate that?
So palpation I can demonstrate on visible, like visibly on inspection we can look for reduced chest expansion while the child is lying down, and when we inspect from the.
So you show how that is to be seen. So do you want to say that there is a chest asymmetry?
So visibly there is no chest asymmetry in the shape, but there is asymmetry in the expansion of the chest.
That's very unusual. That's very unusual.
How will see that decreased movement?
Late ja bete.
Moreover, which will be a better position to look for this asymmetry? In this position, will you be able to better judge an asymmetry, or in any other position? From which angle should you look for asymmetry?
From the
maybe in a lying down child, from the head end or from the toe end, you will be able to better make out the asymmetry rather than this lateral.
So it should
So
be tangentially. Just to
make
demonstrate
the child,
it. Demonstrate it. सिर उधर कर लो.
Sir, right side.
हाँ.
So
Straight.
The child should be absolutely straight, as sir said.
Now this child is lying down, and we see from the foot end. Dr. Mehta will see.
Yeah.
Now you tell your findings and he will confirm.
So which side it is decreased, right or left?
Left.
Left side. In the lower chest it is decreased. है ना?
Yes, sir.
Okay. But right side it is more, I think, in upper part.
I think it is the right side.
Right side it is.
The right side which is depressed.
Which is
Stand
slightly
here.
depressed.
Yes, the right side which is more depressed. The left side is not depressed. And if you look at the movement also, it's the right side which is moving less. So I tend to disagree with you.
So with this change in position and 3 experts.
Let's go further.
So no other spinal or chest deformities are visible. The apex beat is visible in the 5th intercostal space and in the mid-clavicular line. Sir, then upon palpation, sir, the findings of the inspection were confirmed, and the chest expansion appeared to be reduced on the left.
You will have to demonstrate.
Yeah.
You can leave the mic, just do what you want.
Dr. Bhavna will help. And
डॉक्टर साहब को जहाँ ये दिखाएंगे ना वो दिखाएंगे.
yes, we'll request the camera to please focus onto this.
थोड़ा सा ऐसे मुड़ के दिखा दे सर. So placing our palms on the side walls and then making the child lie straight and with the head in the midline. We need to see the expansion of both, while approximately the thumb, we need to see the expansion
So
over here.
better just you keep it here and different areas, and expansion in different areas, not only. Huh?
Yes, sir.
So just you move here, you keep both, and just सांस लो बेटा, लंबी सांस, लंबी और हाँ. So which side movement is less?
Appears to be less on the left.
No. Just you see movement is less on the right side. Oh, sorry, left, left side. Movement on left side. Okay. Then suprascapular, another, that also you can see. Okay. So movement is less on the left side.
There are several ways one can look at the chest movements. The moment we have chest asymmetry, the problem is we are saying one is depressed or the other is elevated. Which one is bad, the depressed one or the elevated one? Because they are relative to each other. And the answer which will come from the where do you have the less movements. So if there is air trapping or a mass which has given rise to a prominence on one side or maybe a huge effusion, you would have less expansion on that side. Or if it is collapse or a destroyed lung which is causing or a chronic pulmonary or pleural fibrosis which is causing depression on the other side, then that will be less movement on that side. So it's the movement which tells you which side is abnormal. Asymmetry is just asymmetry. It doesn't tell you this asymmetry which side is abnormal, right? So the methods which we use are, one, the child should be sitting absolutely straight, comfortable. थोड़ा सा सीधे हो जाओ बच्चे, सीधे होकर बैठो, बस ऐसे आराम से घबराओ नहीं. And you see in the center, आप मेरे हाथ पे फोकस कर सकते हैं कैमरा को? इसकी जरूरत नहीं है.
As sir said, the child should be made to sit straight.
लंबा लंबा सांस लीजिए. And you come and stand here and see which side is moving less. लंबा सांस लो बेटा. Now you tell me, is it more on the left or right side? There is hardly any movement on the right side. It's the left side movement which is less. आप बीच में आ गए वो कैमरा पे नहीं दिखा पाए, but it's the left side movement which is less. थोड़ा सा
No.
ऊपर so that others can see.
In the back also we should see. We have to confirm, sir.
Yeah.
In the
other
back.
way is you
Yeah.
can put your hands like this and then see which hand
Yeah.
is getting lifted. See, as the child is breathing, there is some lift here. You are hardly seeing any lift of this hand. That also means the right side which is diseased, and it's the right side which is depressed, which is abnormal. Okay. Likewise, we see at the back. जब घूम के बैठ जाओ,
घूम जाओ,
जब थक जाए तो बता दियो, हाँ? थकना नहीं है,
ये रख लो,
हमने आपको थकाना नहीं है, अगर आप थक जाओ तो बता देना, फिर हम वहीं बंद कर देंगे इसको. लंबा सांस लो. Now again the movement is more on the left side. This hand is moving, this is hardly moving. Posteriorly, the asymmetry is less. Anteriorly, the asymmetry is more. What does that mean? Upper lobe involvement. That means there is more likely to be an upper lobe involvement, and that is why we are seeing more differentiation anteriorly than we are seeing in the infrascapular area. So that is the relevance. Yeah, that is the relevance of doing both anteriorly and posteriorly. You just can't do it one side and this side. Okay, let's go further.
Somebody has asked, is it the Harrison sulcus that we can see in this child?
Okay, is there a Harrison sulcus? Harrison sulcus is best visualized in a lying down position. Okay, so maybe we'll have to make him lie down. Are there any other examination we have to do in sitting posture? We can come to it once the child is lying down later on.
Yes.
Okay.
On measurement, the chest expansion is reduced, which is 1.5 centimeters in this child. And
what is the normal chest expansion at this age?
So at 12 years, the normal chest expansion should be more than 3 centimeters at least, while breathing at rest and not on deep inspiration.
Normal tidal breathing, you expect a 3 centimeter inspiration
Minimum.
Minimum in a 12-year-old
12
child.
years.
However, one of the problems with these measurements is we do not have age-related norms available with us, that how much is that expansion at a given age. This child happens to be just the adolescent and just at the age where we have some ideas, but in younger children this becomes a difficult tool for us to assess because we do not know what is normal for that given age.
And the trachea appears to be slightly deviated to the left side. This can be demonstrated.
आप गले पे फोकस कर सकते हैं? गले पे.
Keeping the index and the ring finger. So keeping the index and the ring fingers on the medial ends of the clavicle, we trace the trachea from upwards and below up to the suprasternal notch, and we see the deviation of trachea to the left side.
Is there any other way we look at it? What is the trail sign? सीधा रखो. Let's call somebody else. They seem to be sleeping now. Why don't you come, Himan? I know you are not sleeping. It's just अब मुझे भी तो कुछ कहना है ना, मेरे हाथ में माइक है. So by inspection, what do you think? Where is the trachea shifted, and how do you make that? What is that sign called? She wants to confirm that by that. In the interest of time, I will quickly mention that. One is, child should be sitting absolutely straight. Now we are having him in little contorted postures for the benefit of the camera, but that's not the right posture. He should be absolutely straight. And then putting both the fingers on one side, we use the middle finger to go down and see whether this finger is right, stays in the center or goes to one end, and it's going towards left side. Okay, that's one way. On inspection itself, you look at the medial ends of the clavicle and see the insertion of the sternocleidomastoid. Is any of the two, which of the two sternocleidomastoid is more prominent? Is there a difference? This or this? Sure. Look carefully. You can see this more clearly. You are hardly able to see this insertion. So I would say again the left-sided sternocleidomastoid, and that's this sign which we are describing, which is possible, which will share that, confirms our finding that it is on the left side. You can further see, if you try to put your finger in between, it's harder to push this finger here, and it's easier to go beyond the sternocleidomastoid on this finger, and that shows that this is deviated towards the left side. So there are three ways we can look at the tracheal deviation, and all of them confirm that this is left side.
The tactile phreatitis was observed in all the lung fields, and it appeared to be increased in the right infraclavicular area compared to the opposite side. That is the left. And further, sir, on percussion, examination was done in all the lung fields bilaterally, and there was a resonant note observed in all the lung fields. There was no hyperresonant or any dull area of dullness that was observed.
What specific areas did you look for to say? You said it is not hyperresonant. Why were you expecting hyperresonance in this patient?
Sir, any pneumothorax or
pneumothorax with chronic history, or anything else?
emphysema.
Emphysema secondary to what? So air trapping. Emphysema is a very poor word. Emphysema means destruction of alveoli. We have very little causes for such destruction of alveoli which will give rise to emphysema. We often use that as a kind of a semantic, wrongly, not rightly, but wrongly use that as a semantic for increased air in the lung. Just as we call congenital lobar emphysema. There is no destruction there. It is just that you have large amount of air in. So emphysema is not the right word. The word is hyperinflation. So hyperinflation, air trapping. So again, as we discussed, it could be any obstructive disorder, any small airway disease, bronchiolitis obliterans, an ILD which complicates it, CF with small airway disease, not exactly in this cell, which situations which can give rise to hyperinflation. A poorly controlled asthma, commonest cause. So in those situations of hyperinflation, what will be the signs on percussion you will look at? Anybody? Lost faces. Okay? This program is being relayed all over the country. Then LHMC is going to tire out this fast? That's very sad. You haven't heard about masking of the cardiac and hepatic dullness? When does that happen? Hyperinflation. So that's part of percussion. So when you said there is no hyperresonance, it's not only the note in the normal areas. It's equally important to talk of where did you get your cardiac dullness, where did you get your hepatic dullness, and whether it was at the right place or not. Right? So what was it?
The hepatic dullness was observed in the right fifth intercostal space, downwards, anteriorly, and the cardiac dullness was observed from the second intercostal space on the left up to the.
There was no masking.
So there was no masking.
We have not seen any sign of air trapping in this child.
Yes.
Okay. Did we talk about the AP diameter somewhere? I'm forgetting. Did we talk about the diameter of the chest of the child? I didn't hear that. Why? That's an important part of your inspection and palpation. You have to talk about the AP diameter and the transverse diameter, and if your AP diameter is more or equal to transverse diameter, then that's another sign of hyperinflation. So you should have checked that in this child. which is a very important piece of information to tell us again what type of diseases we are dealing with. So from visibly, it doesn't look like that his AP diameter is more. He doesn't look to have any air trapping or an inflated chest. But a measurement should always be done.
So for the auscultation, breath sounds appear to be decreased in intensity in the right infraclavicular, inframammary, infraaxillary, and the right interscapular and infrascapular areas. And creps were heard bilaterally in all the lung fields and were more present more in the right interscapular and infrascapular and in the left infraclavicular areas. And wheezing was also heard in all the lung fields bilaterally, which was end expiratory wheeze.
So there is wheezing and there are crackles. Okay. Anything else?
No bronchial breath sounds were heard. And although breath sounds appear to be more harsh on the left side as compared to the right, but there was no bronchial breath sounds.
One important thing in medical examination is you must always be able to link. If your findings are correct, most of them you should be able to link them together. Now you described earlier one side, we came to an agreement that the left-sided, there is a left-side decreased air entry, there is a left-sided decreased air movement, there is an asymmetry. So you haven't specifically commented at whether the breath sounds are equally heard or not equally heard, particularly on the left side. Have you? Or did I miss it?
The expansion appeared to be more on the right when it was confirmed, and I mentioned that the breath sounds were heard less on the right interscapular, infrascapular, infraclavicular and inframammary areas.
So almost all over. From our earlier observation, where asymmetry was more evident anteriorly than and the hand movement or the expansion was more affected anteriorly than posteriorly, which suggested that possibly we were dealing with an upper lobe disease. Here on auscultation, what you are finding is that it's a decrease both anteriorly as well as posteriorly. More so anteriorly than posteriorly, or there is no
more difference? So anteriorly.
More so anteriorly. So that again, as I said, you will be able to link up most of your findings if your findings are correct. And if you are finding gaps in between, it is always worth revisiting that you may have wrongly assessed some finding or picked up something which is not there.
Sir, at the same time, sir, tracheal shifting to the left maybe does not corroborate with the rest of the findings.
Well, I can still explain it with the disease on this side, but let's see how it goes. You have a point, because when it is shifted to left, you expect a left side pull or a right side push effect, right?
Yes, sir.
So suppose there is a large bulla on the right side which is pushing. This will explain your decreased breath sounds. This will explain also large bulla will with an underlying lung damage will not give rise to a over distended chest, but will give rise to a less distended chest because underlying lung is damaged. So there can be a shift with that. I do not know. We will see when we look at the chest X-ray and other things. I don't remember what was the finding in this child, but we'll see.
Upon cardiovascular examination on inspection, the apex beat, as mentioned in the respiratory examination, is visible in the fifth intercostal space in the mid-clavicular line. And further on inspection, there is no visible scar marks or sinuses are visible over the chest wall. And then on palpation, the findings of infection, that is the apex beat has been confirmed. That is again present in the fifth intercostal space in the mid-clavicular line, suggesting no cardiac enlargement. And followed, there is no parasternal heave, there is no palpable murmur, no palpable heart sounds, and
what were your intentions when you did a cardiac examination on this child? Were you thinking of, as was mentioned earlier, for a underlying heart disease, or are you looking for something else? What's there in your mind from the history? Because we must always anticipate from a good history and other signs what to expect on examination. That doesn't mean that we specifically look for something, but there is, again, as I said, always a chain of thought, and there is always a linkage between the findings. They're not standalone, unrelated to each other. So what do you think was it?
As per the history, it was suggestive of a chronic lung disease. So an increased pulmonary artery pressure can be expected in this child, and accordingly, I had mentioned about any palpable.
So you were looking for col pulmonale.
Yes.
So did you find any other evidence of CHF in this child on abdominal examination? Did you do an abdominal examination?
Yes,
so what are the findings on this?
So the liver is only 1.2 centimeters below the costal margins and is soft in consistency, non-tender, and there is no hepatojugular reflex is observed, and further on. There is no palpable P2.
You mentioned that this child was admitted in a sister organization with an acute decompensation when he also needed assisted support, which I understand possibly would be ventilation. So at that point of time, was there any history of any pain in the abdomen or right hypochondrium or swelling? You did mention puffiness of the face.
Swelling was present, which was on the mainly facial and on the feet. However, as I asked the parents about any particular abdominal pain, they have not made a mention, but maybe at the same time the child was not able to express as many symptoms
because he was very sick at that.
Acute decompensation.
It has been asked in question also. What do you attribute this facial swelling and edema to? Why was it there when you said this in history?
We'll hear her summary and then possibly we'll know what it is. So is there anything else on the examination which is left? Why you ask so many things about connective tissue disorder in your history? You don't want to look for that stigmata or their involvement on your
general physical examination. I made mention of any skin rash.
It would still be worthwhile talking of these joints and skeletal system. But if you were so interested in knowing whether it was a sequelae of a connective tissue disorder, I think it was worth it talking of it here.
So visibly there is no joint swelling in any of the
areas. There is no history either. Okay. So can you please quickly summarize your case, because we seem to have done our history and examination on a very, very long time.
So we have a 12-year-old male child presenting with a prolonged history of fever and cough, initially off and on, and now the cough being continuous from last 4 months, along with the onset of dyspnea from last 4 months and episode of facial and lower limb swelling around 2 months back, which have gradually improved on receiving nebulizations off and on, along with inhaler medications, along with some certain oral medications. And along with this, there appears to be reduced expansion of the right side of the chest in this very thin built child, and along with the presence of reduced breath sounds on the right side, as well as crepitations and wheezing present in all the lung fields.
Okay, so
with no evidence of any pulmonary artery hypertension on examination.
What are the possibilities at this point of time?
Sir, at this point of time, I would like to stress on the possibilities of any interstitial lung disease which is causing such prolonged symptoms of cough, which has been predominantly remained dry, and history of fever not being very significant. And the likely etiology of interstitial lung disease appears to be infective in this child, because initially the symptomatology was intermittent. So maybe certain infective etiology which has predisposed to.
But then you say, on one hand you are saying that fever is not a significant feature. On the other hand, you are saying that it is because of infection. Why is it not a common thing? Why are you thinking of ILD? Why is it not simply a child who has a family history of contact, a child with MDR TB. So that is why I think a very important component in your history which was relevant and is missing is the what happened in the treatment of that contact. So do we know more about that mother rather than TB? जो इसकी माँ को TB हुई थी, उसका इलाज कहाँ से किया था आपने? Is there a mic?
प्राइवेट से कराए थे।
प्राइवेट से कराए थे। तो कितना समय इलाज चला था?
पहले का तो पता नहीं लगा था, बाद में 6 महीने तक खिलाए थे दवाई।
लगातार इलाज चला था कि बीच में छूट गया था?
नहीं, बाद में तो बीच में छूटा था, पहले बार में छूटा था।
पहली बार में छूटा था, दूसरी बार में ठीक से कर पाए थे?
पूरा ठीक से।
तो जब दूसरी बार इलाज चला था, जब छूटने के बाद, तो उसमें क्या सुई हुई भी लगी थी कि सिर्फ खाने की दवाई?
सिर्फ खाने की दवाई दी।
सिर्फ खाने की दवाई और 6 महीने ही इलाज चला था।
6 महीने।
और उसके बाद वो बिल्कुल तंदुरुस्त हो गई कि उसके बाद कुछ बीमारी चलती रही?
नहीं, उसके बाद भी दुख बुखार आते रहा, बुखार आते आते फिर वो गुर्दा में तकलीफ बता दिया।
अच्छा, तो गुर्दा में तकलीफ बता।
फिर
now this could very well be a MDR contact. He is very clear that he took treatment which was irregular. Okay. Second time mother was given the same treatment, it was not given category 2, even which we today question whether it is adequate for retreatment, and the mother remains symptomatic thereafter, and there is some gurda ka taklif which we need to understand in more details from the papers. So would you keep a possibility of MDR TB in this child?
Sir, second I have kept the possibility of multi-drug resistant pulmonary cox.
Why? Why second, and what are the points in favor and what are the points against?
Sir, the long-term symptomatology of fever and cough initially appearing intermittently and with followed by symptoms of weight loss and reducing appetite.
वहाँ बिठा लो आराम से। एक हैरिसन सल्फर दिखाना था ना, एक मिनट लेटा दो, 1 मिनट लेटा दो सिर्फ। 1 मिनट लेट जाओगे बेटा गुलबेज? 1 मिनट। So there was a question whether there is a Harry sulcus in this child. So what do you think?
There is a depression in the lower, along the lower intercostal areas bilaterally. However, it doesn't really corroborate with the Harrison sulcus, which is present along the attachment of diaphragm. So we see
a very
groove.
important thing which we must remember is that Harrison sulcus is seen in younger children when the chest is more compliant with a chronic disease, where there is a regular pull by the diaphragm. This child's onset of illness is at 10 years of age. That's an unusual age at which you will have enough compliant chest to produce a complete Harrison sulcus. However, if you look at this flaring of the lower chest, it will give you an impression that there is a tug, because it's a largely abdominal breathing which is happening. So one may call it, but truly this is not a description of a Harrison sulcus. So I will leave it at that. Can you?
There is one, Dr. Pramod Kumar, he is very convinced that this looks like a Marfan's because the hands are too big for the child and he is able to fold his fingers back. But I think if she has taken the arm span, that will be a better answer to this, more objective answer to this question. And moreover, because of clubbing maybe, the fingers are looking bigger than what they are. But if arm span has been taken, should have been. Could have been.
We could check that.
And another question that he asked is that the liver is 3 centimeters below costal margin.
No,
so
not 3.
1.2
centimeters. I think he has read something wrong, but he was trying to corroborate this below costal margin with span. I would say that span has nothing to do below costal margin.
Yes.
It can be pushed down because of whatever reasons, and span will not change with that. So below costal margin, palpable liver does not always
liver, it not
corroborate with
enlarged.
a enlarged liver.
You can have push down liver which may be palpable, and that is why liver span is more important than how much of it is palpable. Though conventionally we talk more of how much of it is palpable, because unless until we have reasons from our examination to believe that it could be pushed down, like a hyperinflated chest. Yes.
So coming back to the differentials that we were discussing earlier, sir, I had kept the possibility of interstitial lung disease earlier because the point that goes more in favor of interstitial lung disease is the improvement in symptoms that we have observed now with the course of our treatment that we have given with the inhalers, nebulizations, and along with oral medications, which does not include any medications for any multi-drug resistant pulmonary.
Let's forget what we did here. Say this child had come about, he has been with us for how long? About 1 month?
1st September.
1st September.
1.5
about 2 months, 1.5 months. So suppose this child had come 7 weeks earlier. At that point of time, would you have kept a possibility of an MDR tuberculosis? Yes or no? What are the points in favor or against?
I would have kept
your involvement started 7 weeks back and not today. We may be presenting him today.
The point which goes in favor of multi-drug resistant tuberculosis is that the child having prolonged symptoms of off and on fever and cough, now being progressively increasing, and along with the symptoms of reduced appetite and weight loss, which in a setting like ours has increasing chances of tuberculosis, and that has not responded to 2 antitubercular medication courses that has been provided to this child. However, the negative point going against is the partial improvement that was improved with off and on nebulization that the child used to receive from the local hospitals, and there is no direct evidence of any antitubercular of any tuberculosis was present according to the sputum analysis and other investigations that were done in this child.
Anybody else would like to add or agree or disagree with this? Anybody here would like to add anything? You know, what I can't understand is that you have a child with drug-resistant TB, and when you are coming to a conclusion that it is drug-resistant TB, his fever disappears, his cough decreases, and it becomes more of breathlessness. How are we explaining that? The presence of clubbing in tuberculosis happens with fibrocavity disease or chronic suppuration. We clinically have some evidence which could mean there may be a fibrocavitary disease, but do we have any evidence of suppuration? We do not have evidence of suppuration. We do not have fever. That's one thing. The other thing is drug-resistant TB in a child who has not responded to treatment. What is the response to treatment? If I give treatment of TB to someone who does not have TB, will never have a response to treatment. So response to treatment is when your initial diagnosis of TB was conclusively established. Have we any evidence to say that it was conclusively established at the first or second point? We do not have. जब आपका दूसरी बार इंजेक्शन वाला इलाज शुरू हुआ था, जब सरकारी में आप गए थे, तो उस समय क्या टेस्ट हुए थे? कैसे पता लगा था कि उसको टीबी दोबारा हो गई? उन्होंने डॉक्टर को जहां आपने दिखाया था, उन्होंने क्या जांचें करी थी? कोई बलगम की जांच करी थी?
बलगम की नहीं करी थी, उन्होंने सीटी स्कैन करवाया था।
सीटी स्कैन करवाया था, और सीटी स्कैन के बाद उन्होंने कहा कि टीबी है।
हाँ, उन्होंने उसके बाद बोल दिया कि टीबी है, तो फिर बलगम की जांच करवाया, तो बलगम तो इसको आता ही नहीं था। हाँ, तो कभी आए नहीं, वैसे झाग आता रहा, 4-5 जाते,
बलगम कभी ज्यादा आया ही नहीं, झाग आता,
झाग आता था। उन्होंने दवाई चलाना शुरू कर दिया।
ठीक है। So here again, where is the evidence of TB? So non-response does not make it MDR TB, but given the fact there is a definite history in the family, it will remain something to be ruled out. So your other possibility is ILD. Why ILD?
Sir, prolonged history of cough, which is predominant in this child, which has been progressively increasing, now causing onset of symptoms of dyspnea, which have been progressively increasing, and fever not being significant, and the cough being dry predominantly throughout the period, is a pointer towards an interstitial lung disease.
Anybody wants to add anything? Presence of clubbing. Presence of clubbing in a child who does not have a wet cough suggests a chronic hypoxemic state, right? You can have for other reasons also. A cirrhotic without cough can also have clubbing, and a celiac can also have, but that we are not discussing those situations. But in a pulmonary or a respiratory case with dry cough, it is a suggestion of a chronic hypoxemia. A chronic hypoxemic state which is gradually developing with dyspnea, so possibility of an interstitial lung disease. What are the clinical evidence? Interstitial lung disease is a bilateral disease or a unilateral disease?
It's a bilateral disease and it's a diffuse involvement.
So why do you have symptoms which are more on the, or you have asymmetry on one side? How is that possible? Is that possible in pulmonary interstitial lung disease?
In interstitial lung disease, there can be differential involvement of the lung fields, and especially if interstitial lung disease has been post-infective.
I think a very important point which Sukriti made here was, to which I agree with her totally, is that it's a bilateral disease, but it does not mean it's a bilateral symmetrical disease. It's a bilateral disease, but there can be differential involvement of the different lobes, and therefore it is possible to have some asymmetry. So I agree with you that. So any other possibility you will like to keep?
Bronchiolitis obliterans organizing pneumonia.
Bronchiolitis, that's another form of interstitial lung disease. So, okay, not typically an interstitial, it's a small airway disease.
It's a small airway, and in bronchiolitis obliterans there can be predominant involvement of some areas of the lung, and there might be patchy impairment of entire impairment of certain areas of the lung. So
what is the most typical feature of BOOP clinically?
Wheezing is more
predominant symptom is wheezing. Okay, so you haven't found as much spasm as you have equally well found Krebs in this child. What else? Do you have any signs of air trapping in this child? You do not have any signs of air trapping. So why are you keeping a possibility of a small airway disease where there should be significant air trapping in a child who has signs of loss of volume rather than an increased volume? You expect an increased volume when there is air trapping, and here you have loss of volume.
Obliterans presentation should be at this age, or it should be earlier with that year?
Sir, it can present at any age depending on the underlying etiology.
That is right. There is no age differential. The younger children have it more with adeno, but the older children can have with many other diseases. Is there any other differential you will like to keep?
Sir, lower down I have kept the possibility of gastrointestinal reflux, gastroesophageal reflux.
About which we discussed earlier. Why not ABPA? Is an asthmatic and now has got clubbing, has got persistent wheezing, persistent cough. What is against the diagnosis of an ABPA, allergic bronchopulmonary aspergillosis? Allergic?
Sir, initial onset of intermittent symptoms followed by
progressive. On your examination, you have a lot of things which are against ABPA. What are those? Yes, you want to say? Mike? जल्दी जल्दी बोलो, लोग थक चुके होंगे.
So there is no on examination there is no stigmata of the allergic things.
Okay. What else? Allergic bronchopulmonary aspergillosis is an allergic to that mycosis, aspergillus. So you may not have necessarily have a background atopy, though it is very commonly seen. But that by itself, again the same thing, the point which was against BOOP is also the point against ABPA.
Predominantly
you do not have hyperinflation, you do not have air trapping. Without air trapping, how can you have ABPA? Because that's largely a disease. If it's a complicated asthma, then it should behave like a hyperexpanded chest with air trapping, which you are not seeing. So that's an important point which is against ABPA. So that brings us back to your first diagnosis, which is interstitial lung disease, which could be secondary to gastroesophageal reflux or something else. But still, to rule out
MDR.
Tuberculosis, because there was fever and there is a history of contact, and mother has not taken regular treatment and continues to be symptomatic. Okay. So what investigations you would plan for this child, and what were done and they were negative or positive? Can you quickly take us through that?
Sir, when the child had...
Short of the radiology, after this we'll take radiology.
When the child had presented to us, blood counts were done at the Vallabhbhai Patel Chest Institute, and along with the test for tuberculosis that included Montu skin test, presence sputum analysis for AFB staining, sputum culture, and also sputum.
Can you tell us the positive findings in the interest of time, because we are close to 2 hours, we must stop this now.
Sir, no significant finding was observed in any of the ultrasound Monto sputum analysis.
Eosinophil?
And even eosinophil count remained normal.
They were normal. Okay.
Less than
So that
300.
takes care of your ABPA. You do not have significant eosinophilia. Your skin tests for aspergillus are negative.
Also for aspergillus was negative.
Negative. And IG was done?
IG was normal. IG specific for aspergillus was done, which was negative.
One can always have the benefit of hindsight. Somebody else has done, it is normal, and I can be more confident in saying they were not needed. But as we discussed and as the case unfolded with us, possibly even if this was a child coming to us earlier, we would not have done these tests simply because clinically this is a diagnosis which comes lower down. What other investigations should we have done?
When the child had presented to us, we had repeated sputum analysis. Along with this, we had gone for bronchoscopy.
So one is to establish possibility of an infective organism. I think this is the time to have a look at radiology to have a meaningful discussion on this. Can we have a look at the X-rays and CTs of this child? And if you wish to come and stand here to see, just don't obstruct that camera. You can come and see. Okay, this is the first X-ray, which is of January. That means this is after the completion of first antitubercular treatment. So we do not have any X-ray or information available of the first episode when this child was given treatment for TB. We have no information or investigations available for that time, except that it had no significant response. And what do you see in this X-ray? Can you describe it?
So this is a PA film in which we can see predominant involvement of right upper and left middle zone with the inhomogeneous opacities present in these two areas, and along with the areas of small cystic changes in the right upper.
You mean these?
These small cystic
You are seeing
areas.
some air spaces between these, and you think they could possibly be microcavities or cavities.
Microcavities, yes, sir.
Okay. What else do you see here?
Along with this, there is there opacities, diffuse opacities can be seen in the rest of the lung fields.
There are
Mild
some
infiltrates
which are inhomogeneous opacities which are seen on the bilateral side. So we have another X-ray which is 2 months later. What do you see here? Is there a progression of disease? Is it same or is it worse?
Sir, it appears to be similar picture. It only appears that the exposure.
दोनों X-ray ले लीजिएगा. ये आप लोग थोड़ा सा इधर आ जाओ so that both the cameras can work. हाँ. There is enough space here. Why don't you come in front? Okay.
It basically appears that the exposure of the film shows a variation in the
So
two
you
films.
think the two films are comparable and the difference is because of radiological factors?
Yes.
Is this what you are saying?
Yes.
Okay, let's look at it more carefully. If you look at it more carefully, when you have X-rays to compare, one important thing is to look at the radiological factors. And if you look at the two films, here you are able to see spine much more clearly through the heart than you are able to see here. That means the radiological factors are different. And this is a digital film, a computerized film, where a lot more post-processing is possible. It's not simply a question of penetration under and over. Here it's like a Photoshop, so you can use different windows and have very, very different things. But what we see is that you had some degree of gray and white in this area, which is now missing. So possibly a cavity here, because I do not see any air markings in this area. Compare this with the rest of the areas where you are able to see some whiteness in between, which shows air marking. But in this area, which is black, you are hardly able to see anything else, which suggests possibly this is a cavity, right? So this breakdown which was happening, now a larger cavity has formed. There is some breakdown also here. There is a fibrosis, but would this mean this child has deteriorated or improved or is static? Based on X-ray, what is the interpretation? X-ray deteriorated or patient deteriorated? based on these X-ray films, you will have to always interpret them in the light of the clinical condition of the child. If the child has deteriorated, this could mean deterioration because there is a new cavity formation. This is healing by further necrosis, and it is not healing, it is causing more damage. But if a fibrocavitary lesion heals by fibrosis, by traction, the cavities can become larger. So it is the presence of infection or presence of symptoms which will tell you whether this is a progression or it is healing or not healing. Based on X-ray, it doesn't help you any more than that. So let's see the next X-ray. And we do know at this point of time child was on category 2. No, category 2 here. So the doctor felt that possibly there was a deterioration, and this is the point of time that they did a CT. Okay, so we'll look at CTs after this. And this is an X-ray which is done when? In July. That's when he said July he started feeling breathlessness. So what's the difference between this X-ray and this X-ray? Are we seeing improvement, deterioration, new findings? What do you see?
It appears that new areas of microcavitations have formed even on the left side.
Where?
On the middle and upper
You had those
areas.
infiltrates here, but now you are able to see cavities.
Microcavities.
Okay. What else?
And sir,
I am able to now see cavity
areas
here,
of
cavities,
breakdown more prominent
and a
on the right.
fibroelectric band here.
Bands.
There is a pulmonary conus which suggests there may be pulmonary artery hypertension. The heart size also looks larger than before. So possibly this child now has started going towards pulmonary artery hypertension, secondary to whatever lung changes we are seeing, and maybe going into a CHF. As yet it is not that large a cardiomegaly which you will say is more than 55%, but from what you had earlier, this heart has become larger in size and there is filling up of the pulmonary conus. So this could explain his distress, that possibly this child had started developing pulmonary artery hypertension and a cor pulmonale, and that is what gave rise to the breathlessness this child had. So that is an important thing to remember, that serial changes on X-rays may not necessarily always mean it's only because of a infection. There could be a secondary reasons beyond para-infectious illnesses. It's healing by fibrosis, or it may be primary illness which was fibrotic in nature. Maybe it is an ILD, and that is causing more hypoxemia. And as the hypoxemia is increasing, because we are not treating this ILD, it is going relentless, and therefore there is now a pulmonary artery hypertension. It is going into cor pulmonale. Can we have a quick look at the CTs of this child? Just show the last CT.
The last CT done at our hospital.
So when you have to see CT, what sequence comes first? Louder.
Mediastinal window.
Mediastinal. Okay. So what's the difference between a mediastinal window and a lung window? Anybody? Yes. What's the difference? How many times this child was exposed to radiation? Here and here. If I ask someone to give me mediastinal as well as lung cuts, and I ask only mediastinal, am I reducing radiation, increasing radiation, or it makes no difference?
You're reducing it. You're reducing.
Use mic and speak.
You reduce.
How am I reducing? The information is collected in one go. Thereafter, it is totally the contrast windows which decide what areas get more prominence. So when we say lung windows or when we say mediastinal windows, it's just the change in the window width, the exposure and the contrast ratios which are done by the computer. It has nothing to do with the patient. Patient has gone. You have taken cuts. This is done post-processing. So this has nothing to do with it. And remember, an important thing for reading CT is, when you are looking at the lung windows, you comment only on the lung and not on the mediastinum. And when you are looking at the mediastinum, you only comment on the mediastinum and not on the lung, because they are not meant to read the other areas. So if you look at the lung windows here, mediastinal windows here, you see that there is some increased opacities here beyond the vascular film, but the contrast has not come up very well in this child. So we can't be sure whether it is because of a lymph node or what these increased density in both the hyla are. But there possibly could be lymph nodes in this area, because we see normally in this area you should only see clear vessels, but you see a shaggy margin and you see hyla which is bulky. This is where you are seeing the first division of the trachea into the two bronchi. This is the hilar region, and these white shadows are not normally seen here in this area, which shows they are bulky. Now let's get to the lung windows here. When you look at the lung windows, our clinical finding was right side depressed with decreased air entry. What you see here is right side and this we also saw on the X-ray large cystic spaces, and that's what you see, right-sided cystic spaces which are running almost whole of the interior as well as the posterior chest, but posteriorly this lung has started coming, and that explains the differential expansion between interior and posterior. So if the good examination, everything can always be thread together, because you have been thorough and complete. There are very few surprises there in the investigations. What else other than these destroyed lung or cavities which you see here? Is it a bronchiectasis which is large, or is it cavity? How do you know this is bronchiectasis or parenchymal? In a bronchiectasis you would have a attendant vessel going along with it. You are not seeing any attendant vessel because it's a bronchovascular bundle, and you are not seeing any parenchymal lesion around it. So it's unlikely to be bronchiectasis. What we are seeing is a parenchymal cavities here. We are seeing parenchymal cavities, and the rest of the lung shows a ground glass opacity. It's as if there is a white wheel over it. You are not seeing a consolidation. You are not seeing a dense consolidation, except maybe in this area where the lobules are not very clearly seen. In this area it's more white, so possibly a consolidation here. But if you look at the rest of the lung, it's not looking as black. It's as if there is a wheel over it, and that's the description for ground glass opacity. That's quite typical for a diagnosis of an interstitial lung disease. So you have a child who has a shaggy margin of the mediastinum, which suggests that possibly of infective origin. You have fibrocavitary lesions. You have lung which is showing consolidation with a ground glass opacity. So therefore, possible diagnosis with this finding would be, it is most likely a post-infectious ILD. It started with an infection, not necessarily tuberculosis, some infection which has progressed, and the immune mechanism, the body immune response has has overshot, and it has led to a situation where you have a para-infectious illness. It is causing an immunological injury. And if you also look little carefully, the opacity is not very great, but if you look here, then this is the root of aorta, and this is the main pulmonary vessel. The main pulmonary vessel is almost as big as the aorta, or maybe larger. And if your main pulmonary artery is larger than the root of aorta, this is another suggestion of pulmonary artery hypertension. So this CT has much more information which tells us that possibly we were dealing with a child who had interstitial lung disease, which was possibly of a post-infective state, which has gone on to a situation and which is giving rise to interstitial lung disease. And all the treatment Dr. Sukriti was thankfully referring to in a very cryptic way, because we didn't want to give information about our case right at the beginning, is that this child was given some oral medication and some treatment and inhaler and has improved. That oral medication was steroids for ILD. We treated him with diuretics and was for his failure. His pulmonary artery hypertension got controlled. And let's check with the child how is he feeling. Gulbez, जब आप यहाँ पे आए थे तब कितना सांस फूलता था और अब कितना सांस फूलता है, बताओगे बेटा? जब यहाँ भर्ती हुए थे तब कितना सांस फूलता था?
पहले तो मैं चल नहीं पाता था सांस फूलने पे, अब है ना चल भी लेता हूँ। अब
चल लेते हो, पर सांस तो तुम्हारी अभी भी तेज चल रही है।
वो बुखार 2-3 दिन से बुखार लगता है ना, तो बुखार पे सांस
अब दोबारा से बुखार हो गया है 2-3 दिन से, इसलिए सांस चल रहा है, नहीं तो वैसे नहीं इतनी चलती। नहीं। So he's very clear. I mean, this child is able to describe his illness very clearly. Because of fever, his oxygen demand has come up. There may be an also a respiratory involvement. I don't know what has happened in the last 3 days. I will check with him, and that possibly is the reason that his distress has increased, and that's decompensating him from what he was earlier. But it's very clear that I was not able to walk. I was very breathlessness, and this treatment has made a difference. So today, the case we discussed, we had a big journey. It was a complicated case. It started with the 20-month history, which was almost a continuum. It took different turns, and finally, it looks like we were dealing with a child who had infections to begin with. We have not been able to quantify or qualify what that infection is because we do not have information or investigation of that time available to that time. Could have been tuberculosis, but not a multi-drug resistant tuberculosis. Subsequent investigation, as I understand, bronchoalveolar lavage and everything was negative. Even a gene expert was done.
Yes,
it
sir.
was negative also for gene expert, and MGIT culture is also negative. So we have conclusively ruled out tuberculosis. We have not continued. We're going to finish category 2, or we have stopped?
We are going to finish around 6 months.
This child came already with about 4 or 5 months of therapy. So we felt it prudent. It will be difficult to say whether this response was to the treatment or it had nothing to do with treatment. We decided to continue treatment, though we still question the diagnosis of TB or MDR TB in this child, and we have given him steroids and we have given him decongestive therapy. So that is what essentially this case is all about. I would request my panelists to add if they have to add anything.
Thank you, sir.
Very elaborate explanation. Nothing for us to say anything, sir. It has been very, very elegantly and very well explained. I don't think we can do any better than this.
Do we have any other questions we need to answer?
So, no, sir. No specific. There is one question that was Dr. Praveen Modi. He has just asked, are there any previous records available for this child, for Dr. Sukriti? Any previous records before this illness?
No, apart from Vallabhbhai Patel, only X-rays and CT scan that he carries, that too from after completion of category 1 ATT available with us.
That's it. Yes.
He has been sick for 20 months, and we have information only for last 10 months. First 10 months we do not have any records, anything available.
Not even X-rays. Last X-ray we had is of this.
First 10 months we do not have any information. So we must thank Gulbez and his father. Shukriya, aap itni der ruke. And thank you all the viewers and the people here. I hope I learned a few things about my patient today because it was dealt with more detail, and I'm sure you all had few points of learning. Thank you very much for joining us today. And there is going to be another session, and that will be subsequently in the month. And IAP is circulating those informations to everyone about when the next sessions of IAP webcast come. Keep in touch, and I think they are good exercises for everyone to log in. Those of you who may have joined later because you were on duty or you were stuck in traffic or anything, a recording of this is available on the website and also of the previous session. And if it interests you, please do go back and hear or watch those for an extended learning process. Thank you very much.
Thank you.
And I thank this audiovisual team here who has stuck with us for so long and made it possible. Thank you very much, gentlemen.
करके देखो क्या